Okay, thank you for joining this meeting, Dr. Florence. And we're excited about the month of October because in the month of October, that's when we have the World Down Syndrome Awareness running through the whole month. And we are partnering with Down Syndrome Society of Kenya to discuss various topics each week with the hope that we can bring some enlightenment or just create some form of awareness for people living with and even people who do not live with Down syndrome. So maybe I can just ask you to start by introducing yourself.
Okay, hi everyone. Hi Teresa. So I'm Dr. Oringe, Florence. I'm a pediatrician, developmental specialist, and also an ECD champion. So I work at Kenyatta University, but I also run a child development clinic at the Gertrude's Children's Hospital. Mm-hmm. And I also have private practice at the Beacon Children's Center.
Okay.
Yeah.
It's a pleasure to meet you. I've heard a lot about you through platforms like Through the Roof. Dr. Jane, I know you've met her. She's always talking about you nonstop. So it's a pleasure to meet you virtually. Yeah. So maybe we can just go right into the topic of the day. How would you explain Down syndrome? Like, if you were to break it down to layman's terms, what would you describe it as?
Okay, thank you for the question, Peter. So Down syndrome is essentially a genetic disorder. And in this disorder, I think the best way to approach it is to say that there is a bit of variance on the number of certain genes that a child with Down syndrome has. And what we know is that genes are packaged as chromosomes. And a normal, typical person would have 46 chromosomes with an extra 2, which are called sex chromosomes. But in Down syndrome, we have like 3 variants. The commonest type of Down syndrome is the full genetic variation, where we have a child having an extra chromosome 21. So the whole package of chromosome 21 is duplicated. And so instead of the child having 46 chromosomes, they actually have 47 chromosomes. Okay. Mm-hmm. But we also have other variants of Down, where children have bits of the chromosome transferred from a different chromosome that's not 21. Of course, it could be also 21, and then attached onto chromosome 20. And that little bit of genes that is attached is actually not a full chromosome, but a portion of it. So that one, we call it a translocation. So sometimes we get children diagnosed with Downs, but when you do a test of their genes, you still find they have the normal number of chromosomes. So in that case, the difference usually lies on that piece, that extra piece that is attached to the 21st chromosome. Then we have a third type where this child does have a variation with some cells having an extra chromosome, whereas others do not have that extra chromosome. So that type is called mosaic Downs, and it's not a very common type, but it does happen once in a while. Mm-hmm. So in a nutshell, what is Downs?
Yeah.
Yeah.
Okay. And of the 3 types of, so since you said the mosaic is not very common, so between translocation, the other, which is the most common?
So the full extra chromosome 21, which we now call the trisomy 21, is the commonest type of Down syndrome that we see. It comprises of almost 95% of the children we see who have Down syndrome. Yeah. So the other 2 will only form like 5%.
And are there statistics, like just if we pin down to Kenya, do we have currently, do we have a statistic of how many children are being born with Down syndrome annually or within a certain period of time?
That's an interesting perspective. Actually, I have no idea of any prevalence study locally.
Mm-hmm.
The only opportunity we had to get some form of data was in the last census, and apparently they missed out on capturing data on disability in children. And so we
Okay,
really don't have data we can rely on. Most of what is available is just estimates from different settings, hospital environments, which are unlikely to be a true reflection. But
that's
what we
true.
know is that Down syndrome is the commonest genetic disorder that we are seeing currently in our communities.
Mm-hmm.
Yeah.
Um, okay, so we had this week we want to talk about Down syndrome and health. Yeah. And so maybe I can ask the question, what are the most common health conditions that co-occur with Down syndrome?
Okay. That's a good question. So, being a genetic disorder, it affects various systems. So Down syndrome, when a child has that extra chromosome material, it does affect a lot of their functioning in different systems. So literally in every system, there's um, some form of difference in how that child functions. So
Mm-hmm.
there are those manifestations that would say is a normal part of the normal phenotype of Down. But then there are those that we say they may or may not be present in children
Mm-hmm.
with Down. So if I would just probably mention some of the common features, like if we talk about the physical features that usually distinguish a child with Down syndrome from any other child,
Yeah.
those are physical things like craniofacial differences. So you'll find maybe there's a bit of up slanting eyes, a flat face and back, uh, flat face and a flat occiput, a small nasal bridge.
Mm-hmm.
So, I mean, most times you see a child with Downs and you can literally pick out that this child has this um, extra features that are subtle but obviously different. But that's just the physical bit. Now, if we go into each and every system, you'll always find something that is not quite typical. So let me
Yeah.
talk of the nervous system. So in the nervous system, the commonest thing that we see is these children delay in their normal development.
Mm-hmm.
So this is a child who may delay in walking, they may delay in speech, they may delay in social skills, and they may delay in other skills like fine motor skills, emotional regulation. So most of those domains will have some interference in terms of independent functioning. Um, but then besides that, we also see that there's a lot of low muscle tone in children with Down. So they have a very floppy texture of the muscles, especially in the early years, like when they're still newborn. Until they have gone through therapy is when their muscles will strengthen up and be able to then pull them up.
Mm-hmm.
We see sometimes of behavioral issues in Downs. So the typical child with Down syndrome is usually this social child who is happy, cheerful, affectionate, warm. That's the typical behavioral phenotype that we get to see. But
Mm-hmm.
then we still see that at least one in every three children with Downs will have one or two differences in terms of behavior. Some of them may have behavioral difficulties, but some of them will have significant psychiatric comorbidity or neurodevelopmental disorders. So amongst the things that we know, for instance, the behavior challenges that we see in Downs is we see a lot of them having autism, but a good number of them. Some may have attention deficit hyperactivity disorder. Some may have oppositional defiance disorder. Some may have OCD. OCD stands for obsessive compulsive disorder. Some show extreme anxiety, some may have some depression, etc. In the older, like adolescent child with Downs, you might end up seeing also things like schizophrenia. So that's as far as neurology. But then moving on to the other systems, if I move to the heart, we have lots of congenital heart issues that may arise in Down. So the child is born with a heart defect.
Mm-hmm.
Um, whereas it's common in most newborns, it doesn't happen in every child with Down syndrome. So some children have it, some don't have it. And some of the cardiac issues are actually acquired later in life. So again, it tells us that we need to be monitoring these children even as they grow. Another system would be probably the intestinal system. Again, in the newborn period, we tend to see a bit of difficulties in that system. Children may struggle with feeding. Children may struggle with some congenital defects, like some of them are difficult ones, like heart sprung, duodenal atresia. So anytime we receive a child at birth, we have to check that their gut system is okay.
Mm.
They are able to breastfeed and they are retaining milk. But beyond that, if we pass that stage and the child has none of those congenital issues, then later we also worry about things like constipation, like reflux, feeding issues. So those may arise. They may be there in the newborn period, but some of them will arise later.
Yeah.
The other system, of course, would be the musculoskeletal system. So because of the low tone, their joints are usually hyperflexible, which is actually an advantage to the child because they can do acrobatics, they can do anything. They're very flexible. But now the worry with that also is sometimes it causes a bit of issues with their joints. And later in adolescence, they may struggle with joint issues. And they also end up having a bit of instability around their neck because of these ligaments are not too tight. And so they're very prone to injuring their spinal cord because of displacement of some of those vertebrae in the neck.
Yeah.
So there are many other systems. I don't know whether you want me to continue with the other systems or pause and let you ask specific.
No, well, you've touched on the items that I wanted to touch on: the congenital heart defect, the digestive problem. So the other thing I had highlighted was the thyroid and their growth and their sleep
So
apnea.
the endocrine system is another major system that can be affected. So most of these children will have some form of hormonal disturbance. Some of it, like hypothyroidism, can be congenital. So the child is born with it, and that happens in 3% of children with Down. And sometimes it's actually acquired. It comes in later. And sometimes as late as adolescents, children can still acquire hypothyroidism. And it does affect how they learn cognitively. And so it's always important that's identified and corrected. But beside the thyroid, also there are other glands that can be compromised. So you can have also like the pancreas can be deficient, and these children are prone to some diabetes. Of course, we look at also the puberty. Sometimes these children have gonadal. Gonads are the sexual organs. So if they have gonadal insufficiency, they might end up with delayed puberty, which is still also hormonal. And so they're prone to this array of autoimmune disorders. So disorders that follow the child's immune system, their own immune system fighting against their own tissues. So you'll find, and for the thyroid gland, if they get an inflammation on the thyroid that is from an autoimmune reaction, they may also get a low thyroid hormone. Sometimes they get the reverse, actually a very high level of thyroid functioning, which is called hyperthyroidism. And sometimes they may also get other autoimmune conditions like skin issues like vitiligo. Other autoimmune arthritis, so sometimes they end up with joint issues. Sometimes they're also prone to metabolic derangements, like they are very prone to gout. So we see a lot of gout in children with Down.
Yeah.
I want to mention about the immune system, because we are talking about autoimmune disorders. Now, one of the things we know, and most parents will struggle with, is the poor immune system that these children will have. So their natural immunity is usually very low. And so because of that, a lot of children with Downs will suffer recurring infections. So this time you're treating for an upper respiratory infection. After a few weeks, there's a tonsillitis, there's a sinusitis, there's a chest infection. So one of the things I'd advise caregivers is to be vigilant about infection children with Down. Because most times these are the things that put the children down. So once they get an infection, their immunity is not strong, so it's likely to overwhelm them. So the earlier it's noticed and the child is sorted out early, the better the outcome.
So if I could just go back to the endocrine issue here where you spoke about the pancreas, is that there, as a result, because I've seen some studies somewhere saying that people living with Down syndrome also suffer from diabetes a lot. Does it come from the pancreatic disorders that arise?
It's part of the autoimmune dysfunction that we see in Down. So we know that pancreas is one of the endocrine glands, and it's one of those glands that can be targeted by the autoimmune antibodies. And so you end up with destruction of the pancreas, so it's not able to function optimally. So we see a very high prevalence of type 1 diabetes, children with Down, compared to the general population. But then besides that, also children with Down have a bit of a metabolic imbalance. So you'll find that their basal metabolic rate may be a little lower. So we see a lot of obesity with Down syndrome, and that starts from a very young age. Their growth is usually a little different from the typical child. One, because they tend to be born slightly lower weight, so low birth weight is common. They may have a bit of short stature because, again, of endocrine issues. And then also the head circumference might be a little small. So generally, they are usually smaller babies. But that variance in terms of growth persists way into adolescence. It actually becomes heightened then in adolescence. So much as we see obesity even in a normal population, the number of children who actually turn out to have obesity is way higher in a population of Down children affected by Down. And actually, by adolescence, we say almost 50% of children or adults with Downs tend towards being overweight or obese. And that itself is a risk factor to diabetes. So we need to try and ensure that these children's growth remains controlled, so they're not gaining too much weight as they continue growing. So we always have to monitor their growth and see that they're not becoming obese, they are kept active, their diets are regulated, so that these children are not becoming overweight.
So as we are monitoring their weight and regulating their diets, are there simple exercises where you would recommend to parents to incorporate in their daily lifestyles?
So there's no one hard rule about exercising in Downs. They're only, the type of exercises are very diverse. I mean, a parent should choose what their child is able to tolerate. But just a caution in terms of exercising, because I know sometimes parents they're almost feeling like they want to overdo it. But a child with Downs has very many other risk factors that would make strenuous exercising very risky. One, the risk of cardiac issues. So you don't want to put a child who has a cardiac illness on a treadmill or doing aerobics for several hours just to get them fit. So you'd have to weigh their condition vis-a-vis how much exercise tolerance they have. The other thing, cervical instability. before a child, like now we have children who actually have Down syndrome and they want to engage in things like Olympics. Part of the assessment requires that they must have good cervical stability. And remember, we are saying almost 14% of children with Down may not have a stable neck. So if you give them very strenuous exercises like maybe the gymnastics we are talking about, or things that would require a lot of flexion on their necks, they might end up with a dislocation around the neck, which will harm their spine. So everything needs to be done in moderation. So it's always good to work with at least somebody who is trained, like exercises with somebody who has trained in that field so that it's not being overdone. And then you always must do it relative to the child that you're dealing. So there's no one rule that covers every child.
Yeah.
Yeah.
Okay, so now I'll keep going back to something you mentioned at each stage. You talked about delayed puberty, and it got me thinking, when now, does it translate into anything? Does it have any repercussions when it comes to fertility of both genders? And if they do, what are they?
Okay, so again, the aspect of low gonadal function, so the gonads, the ovaries, and the testes being a little smaller, it's part of the phenotype of Downs. And so the boy child will have a smaller testis.
Okay.
And so obviously it also means the functioning of the testis. So the hormones are supposed to be produced by the testis, which is the testosterone, may not be adequate to initiate the secondary male characteristics in that child. And even when it happens, a lot of times you end up with children who have incomplete maturation. And so, again, given that scenario, so a lot of male children who have Downs, when they grow up into adulthood, they have very low fertility. So we actually say most of them are infertile except the mosaic. Some of the mosaic type of Down, those can be fertile. And so, again, it's not a hard rule for across the board because sometimes we don't really do tests to know is this guy a mosaic or is he full trisomy 21. So that's for the boy child. For the girl child, again, because the ovaries are not stimulated to work, they are usually they are functional, but not to the extent of the typical age mate. So you'll find that the hormone production is lower, so their estrogen production will be way lower. And so most of these girls attain menstruation way later than the typical pubertal age of girl. But now the interesting thing is that some of them have a lot of anovulatory cycles, but some of them actually are able to conceive. So a girl child, or a young lady, a young youth with Down syndrome, if it is a girl, there is about 30 to 50% in different studies, chances that they will be fertile. So they are able to actually conceive and get a baby. So yeah, that's the position.
Okay. Actually, I think that's interesting because I never used to think about anything when it comes to ladies. I just knew the fertility, had an inkling that fertility in men who were living with Down syndrome was where the issue lay, but that's a great insight on the ladies as well. So I wanted us to touch a little bit on sleep apnea when it comes to individuals who are living with Down syndrome.
Okay, that's another very, very common comorbidity. So we see a lot of children having difficulties in breathing in Downs. So, and again, it draws us back to the structural issues that arise just because this child was born with an extra genetic material. So you'll find that during development, these children have a very narrow nasal passage. So the nasal bones are narrow. And beyond that, because of the narrow spaces, when they have their recurrent infection, they end up having their tonsils growing bigger and bigger. They end up having the adenoid system, which is part of our lymphoid tissue, becoming bigger. And so it's very easy for them to obstruct their upper airway because of those compounded factors. So what happens is that when they now get to sleep, you'll find that the narrow passage does not allow free flow of oxygen through the upper airway into the lung. So there is a delay in airflow, and that is, when it's significant, that's about 10 seconds delay, we usually refer to it as obstructive sleep apnea. So the child falls asleep, and then while they're asleep, they have a lot of disturbance in breathing, and so they tend to wake up a lot, and the early signs is a lot of snoring. So this child will be snoring a lot, and most times they'll wake up, but when they wake up, they're not refreshed because they've had a difficult night. And you'll always notice that they keep their mouth open to be able to breathe better. So when that's happening, then we need to refer these children to the ENT surgeons. So what they'll need to do is to evaluate how much obstruction is there. So depending on the level of obstruction, if it's very significant, it does affect how also the heart and the lung function. So then it means it has to be corrected. So again, we'll see a lot of children with Downs needing to undergo adenoid tonsillectomy just to create a better airway so that they sleep better. And so, of course, improve their outcome.
Okay. So I'm being told we are running short of time, so I'll skip that and take a few questions that parents had sent in before this meeting. So one parent had said, what are the chances that I'm likely that I'll get another child living with Down syndrome in my next pregnancy? I am a worried mom. So what are the chances?
Well, sorry to the worried mom, but so Downs is really a genetic condition. And what is the biggest determinant as to whether recurrence will happen is usually the maternal age, because mother's age is a big risk factor. So if you have a mother above 40, the risk goes as high as 1 in 50 chance that even their next child will be affected. But if you have a younger mother, now the risk is less for the younger mother, but other factors also play in the younger mother. Like if this child that the mom has is a trisomy 21, and this is a young mom, the risk that the next child would ever have Downs would be 1%. So it's pretty low, 1%, because it's random, a random occurrence. It's low, but not as low as somebody who's never had a child with Downs, because we are talking about like a 30-year-old with a risk of 1%. That means 1 in every 100 risk. It's significant. The other type of Downs, if it is a translocation, the risk is slightly higher. It's actually about 3%.
Yeah.
But now we always say that one of the biggest risks, if the child this mom had is actually like a translocation, but of chromosome 21. So the transfer of material that happened was actually on chromosome 21. So a portion of chromosome 21 came to get attached to the child's chromosome 21. So that in that scenario, the risk becomes way higher. It can go up to 50%. So the bottom line is this: most parents, especially when they feel anxious, we like them to look at the age factor and then determine the type of Downs that their child has, because that then tells us then what's the risk that the next child will also be affected.
Yeah. And maybe now the final question is, what causes Down syndrome?
So again, it's really a random mutation by and large. So what we now know is that aging plays a big role in being a risk factor. And one of the reasons why it does that is just because the efficiency of that initial meiosis process, it's not as accurate as it would be in a younger mother. So the risk of errors is higher as you grow older. But the trigger as to why that happens, it's really random. We don't know what happened.
Yeah.
And so it's really a difficult question to answer because random things, I mean, they've done a lot of tests trying to understand what really made that meiosis process have an error to end up with that extra chromosome, but most studies have been largely inconclusive as to why it happened.
Okay. So
again, let me just mention that in our setting, there's not much that we do in terms of diagnosing children accurately. So much as we want to know the type of Downs your child has so that you can really get to know your risk, it's only when you discuss it with your doctors that you can be told what type of Downs the child has so that it understands the risk. And now we have geneticists who are able to even go further and discuss the other risks that will follow if the child has a translocation and determining what type of translocation or mosaicism that the child may have. So I guess for that mom who is really worried, I would advise that she either visits the doctor to have a discussion on that and more so the genetic specialist.
Yeah. So are you, in your capacity or in the institution that you sit in, both, are you able to recommend, are you able to do that, like to recommend a geneticist?
Genetic testing is very widely available. Knowing the child's number of chromosomes is a very simple test. It's called a karyotype. It's very much available in so many centers. Even where I practice, it is available. But then doing a more detailed diagnostics of genetics, so we call those cytogenetics, which have many different types, like a FISH method or a chromosomal microarrays. Those are more specific tests that look for translocation, or they're looking for evidence of mosaicism. So those require specialized centers, but again, they're still available locally. So I mean, if the mom would like to have that, it's actually available, but that would be in very few centers. I'm not sure where any of the public hospitals does, but a lot of the private hospitals are able to do that.
Okay.
Yeah.
All right. So thank you so much, Dr. Florence, for availing yourself for this session. It's as someone who has been a caregiver and has been a sibling to a sister who lived with Down syndrome, this session is actually so enlightening. I realized that there's still much that I thought I knew that I sat here and I'm like, I didn't know all that. So I hope also to the parents who are watching this will find this as informative as I did. So I just want to ask if somebody wanted to search you up on any social media in case they have any further questions. Are you available on social media?
Yes, I'm on Facebook. Florence Oringe.
Okay.
Yeah.
I think with that, we'll conclude our session. My name is Wanjugunderi. I was the host for today. I'm also a founder of Gilza Wazo, where we also create awareness on developmental disabilities as a whole. So in this month, Down Syndrome Society of Kenya and I are partnering to ensure we have as much content out or are having more discussions regarding various topics about Down syndrome, whether it's health, therapies, access to education, access to employment, and more. So you are our first host for the program. Thank you so much for your time.
You're welcome. I'm most honored to be speaking to parents. I'm hoping that if there are any other questions, they can always get in touch.
Yeah.
Yeah. Okay.
Rosalind, do you have any additions?
No, I don't have any addition, but I was right here just listening to the conversation, and it's very interesting. Thank you so much, Dr. Florence. It's really a pleasure. We notified you last minute, but it's only the thought that came up after. I know you're in the wall. The questions that come up on the wall, we want to give them answers. We don't know how to. So it's good we had to contact a professional.
have a session where we're just answering the questions
Yeah,
as
good.
they come.
Yes.
Yeah, that will be fine.
Thank you so
I
much.
actually feel like we gave her kidogo airtime because as
Yeah.
in she tried her best to compress everything, but I'm like, that's so much. Maybe we can now plan to have more
More
sections that
sessions,
are
yes.
tackling if it's
Mm.
diabetes and Down syndrome, just
Exactly.
one topic, and we can see how
Mm.
much we can get out.
Okay.
Mm.
Thank you so
Okay.
much. Mm.
You're welcome and bye. Nice
Bye-bye.
evening.
Okay, you too.
Enjoy your evening.
Okay.